you very much. Thank you everybody for being here to listen to what is important to our own health. So I've been basically asked to speak on what is gastric cancer and how can we detect it early. So we'll address these two specific questions. And let me get my computer rolling. Okay. So I'm particularly going to address these two questions, and then the rest my colleagues will follow on with. So, as we just learned, gastric cancer is one of the leading causes. Although the number of cases, if you look at people who have colon cancer, if you look at number of people who have liver cancer, there might be much more people with breast cancer, women with breast cancer. There might be much more than the number of people who actually suffer from stomach cancer. But it is one of the leading causes of death. So people who do get this tend to have it relatively rough as compared to other cancers. So essentially that's what we want to know. So why do we hold meetings like this? Is to promote awareness so that people are aware and actively look out for. You know, we have a common culture, when they come, then we go and do something about it. No, this is not that kind of thing that you want to wait for something to come and do something about it. You want to be a bit more proactive. So what we will do is we will try and help each other during the talk, and we will try and gain some knowledge into our own health. So this is essentially what the stomach looks like, right? So everybody has a different interpretation of the word that is a medical word, which is called gastric, which essentially means the same thing as stomach, which you see on the top, right? Now, when you say I got gastric, some people refer to it as a reflux disease, which means a heartburn here. Other people say, oh, bloating sensation is gastric. So when you go to your doctor and you say simple things like, oh, I got gastric. Now, I need to think twice. What does this patient actually mean by saying gastric? So we query and ask questions to help us further analyze what the actual problem is. So for making it easy, this stomach, or the gastric, which we call, is divided into a few parts. So not something that I want you to know, but you can see this bean-shaped organ, and this is what the stomach is. On the top here is where the food pipe enters into the stomach, and at the bottom here is the exit where the food will exit out and will get digested in this portion of our intestine. Now, if I take a small piece across this, coming from outside and going inward, then this on your right hand is what the stomach looks like. Okay? Now, most of the growths or cancers that happen in stomach, most of them, I don't say all of them, actually arise from the innermost layer here. Okay? And that is the cancer that we're going to talk about. That is called the gastric cancer, commonly in medical terms called as an adenocarcinoma, but to a common man, that is the gastric cancer we're talking about. All right? So, is there any person who is specifically at risk of having this cancer is something we need to know. So, if you're 19 years old, if you're 20 years old, is that something you should be worrying about in your early teens? Or should you be worrying about when you're 60? So let's have a look. There are a group of patients who would have this cancer coming from genetic lineage, right? But that number of patients who will come with a gastric lineage is extremely low, even lower than 5% of the population of these patients, okay? So it is not an inherited cancer in majority of patients, okay? So if a family member gets it, doesn't mean that the offsprings will get it, that the siblings will get it, and other people will get it. The answer is no. Largely in medical terms, we call it what is called sporadic in nature, which means it just comes out from nowhere. All right? So, what are some of the non-dietary factors, non-genetic factors that actually induce these kind of cancers? And if you look here, I've said diet. Now, eat too much kimchi? Nobody knows. Yeah, you can say it's high in salt, it does. So, what I'm essentially trying to say is that just diet, just the type of food, just smoking, just having alcohol does not mean everybody will get the cancer. right? So if you smoke, if you drink, and you eat kimchi for that purpose, and the way you prepare your food, would you get cancer? The answer is no. These are risk factors. If somebody has a problem or a delusion towards getting something, the chances are that this will contribute to making that problem worse. Right? So diet is important because we can change and modify these risk factors. Okay? There is one pathogen which is a bacteria, which is called Helicobacter pylori, which some of us may innocently harbor as well and not know about it. Others may have problems like ulcers, others may get cancers, but it is one of the causative factors that is led to cancer progression. Okay, some people with previous surgeries will also predispose to having this kind of cancer. So, again, having a risk factor or even several does not mean that the person will get the disease, right? So, don't be too anxious about if you're eating something at all. But it's good to improve. Okay? So here's Helicobacter pylori. A vast majority of these patients with bacterial infection with Helicobacter pylori will not develop cancer. Okay? So because I saw so many people hands up in the audience saying, wow, we had an endoscopy. So if you've got an HP infection before, does not mean you're going to have cancer, right? Okay, so it's just a risk factor, you treat it, we've modified the risk factor. Okay, it does increase, as we said, risk of gastric cancer, largely spreads through food and water contamination. So if you've had one before, or if you diagnose one in future, then the best thing is keep your utensils separate from others, because there might be other members of the family who might have it, or some friends, or your common eating places. So try and keep your utensils separate from others so that you don't contaminate. Right? And again, bacteria alone does not cause the cancer. It needs that environmental and genetic hit to combine before a cancer happens. Okay? Okay, so how do we get along with the diet and every bit? So maintain a good, healthy lifestyle, and basically exercise well, and that's about what we can do. So if you do smoke, try and stop smoking. It's tough, but yes, it's definitely achievable. Have a diet which is adequate in fruits, vegetables, essentially meaning fiber. All right. Avoid too much of salted food, salted egg yolk, salted dried fish, kimchi, lots of high amounts of sodium. Okay. Smoked food, because when you smoke food, there are chemical changes in the food that can produce some elements which can hurt the stomach. So, should I not eat any smoked food? I love smoked food myself. Oh, it's okay, once in a while it's alright, but cannot eat every day. Right? Okay? And preserved food. Okay? Try not to eat them. Why? Again, because they have high content of salt, because they use elements in preserved food that can prevent the bacteria from growing, and which are not necessarily good for us. Okay? So that's how we will try and help ourselves. Now, weight reduction, treating infection, and screening of high-risk population, to which I will allude a little bit in a minute. Now, so the first thing that you want to detect this early begins with actually the patient, right? Doesn't begin with the doctor. So the patients themselves need to know what to look for, or the population at journal needs to know what they should look for. Okay? Can't just walk in and the doctor say, oh, I want to come here, I want to see whether I got gastric cancer. Like this, you were turning up at so many clinics because there's so many different types of cancer that by the end you probably spend a whole month going to doctors, and at the end of the day you will do nothing. Alright? So let's try and find out what is really happening. Okay? So if patients actually having weight loss that they did not want to happen, that is what unintentional weight loss is. Right? You eat normally, still the weight is going down. You're doing everything, still it's going down. Does that mean everybody with unintentional weight loss has a cancer? The answer is no. Again, when patients come to us, we will work up. There are other causes of unintentional weight loss. So this is not a generalizable rule. But yes, if there is, then certainly something to seek advice on. Okay? Don't feel hungry. Okay? As we age, I know there are many people who are senior and there are younger ones here. As we age, the appetite decreases. That's a natural progression. But if you were eating like 2 months ago, can Walla Food, can go buffet and spend the $100 and earn the $100 back. And now suddenly in 2 months' time, you feel like you can't even eat bowls of noodles or things that really good. That's something to be worried about, all right? Okay. Difficulty in swallowing and vomiting, feel something you eat is stuck. If it's been stuck for the past 20 years, then it's not any cancer. All right, there's something else that can go wrong. But if it's just something new, then that's something again to be a little concerned about. All right. When I mean stools like coal tar, for those of you who drive, and for those of you who do not drive, these two speakers that are in front of me, that's something what coal tar looks like. The other property of coal tar is that it is never solid in nature. It's always like a slimy little puddle kind of a thing, all right? So that's what looks like coal tar. Okay, so it's dark. If you take iron, it normally gives you constipation, doesn't give you that kind of stool, all right? Changes in the color. You're going to see, hey, last time I see you very pink. Now how come you very white? Don't look very healthy. Things to worry about. Getting yellow in color. Okay, things to worry about. So need to go back and look at yourself. Right? If patients have a past history of cancer, past history of stomach pains with peptic ulcers, the ulcers do not become cancer in majority. There might be people in the audience who had ulcers before, they had biopsies. That doesn't mean the ulcer will become a cancer. No, it does not. Okay? They start off as cancerous. It's just that these ulcers are probably cancerous ulcers to begin with. And if you do have a history of gastric cancer before, then it's always nice to see a doctor because then we can help and screen patients. Okay? Because some of these cancers we pick up very early, we treat them, patients are virtually cured of the disease, but then they need to be on follow-up. So these are some of the things that as a general public we all should be aware of, because today or tomorrow, one of our loved ones, somebody we know, may be inflicted by the disease. Okay? This is where it comes. Strong history of gastric cancer. Okay, grandfather had it, father had it, brother had it. Okay, now it's me who's having it. Okay? So it's largely common in the older group, the Chinese ethnicity for some genetic reasons. And as I said, largely, many patients can have no symptom and just come into the clinic or into hospital, and that was the first attempt at diagnosis. Right? When we have this, we try to investigate. So what is the best way? We try to find out how can we find it out early. Right? Generally, what we ask the public and our patients to do is, when you come to clinic, please try and speak to the doctor, communicate with the doctor. Right? Tell the doctor what you feel. Okay? We feel like when we sit in the clinicals, we are more of interrogators than people who are supposed to be listening, because the patient does not want to speak. Okay? We can find some things on examination. Just by examining, we can find certain things. There are no real laboratory tests. They tell you, oh, got cancer marker. For stomach cancer, there's no cancer marker. All right? They do not give us clues. The best tool to diagnose cancers of the stomach is to do what is called an endoscopy. Essentially, what we basically do is about the size of my finger, we put a telescope. After the patient has gone to sleep, you do not remember or feel anything. The mouth is straight and it is numb. A scope goes down gently, takes about 5-10 minutes, have a good look inside the stomach, and come out. If there's anything abnormal, taken out. It's largely a very safe procedure with only about a 0.0 or 5 or less than that risk of complication, and that too not of a severe complication. And I will just share some of the pictures. You can see here, that's the cancer growing. You can see in the stomach large ulcerations here. You can see here some food particles remaining in these patients. So these are patients that we can normally find. And sometimes even high up here you can find cancers. And so this is the kind of imaging that we can get, and they're high definition imaging. So it is possible, and it is possible for us to protect. So why do we need to do this? Because we're trying to bring these cancers early to prevent our patients from dying. If you look at this, this is the stage of cancer, and you see in the early days our cancers were all late cancers more than the early cancers. So we're trying to shift this paradigm from here to here. Okay, that's essentially what we're trying to do from advanced cancer to early cancer so that we can pick up. And even within endoscopy, which is the camera view, we can change the color, make it sometimes blue, green, brown, to try and find growths which are very early and can be treated. Okay, I won't go into the nitty-gritty details of that. In advanced cases, obviously, we have to rely on CT scans to give us the answer. Okay, so this is a case of an advanced cancer. You can see all these white flakes staining the inner lining of the tummy of this patient. Okay, so the thing that I wanted to largely share with you is if you look at international survivors and survivors of cancer for stomach, overall 5-year survival for stomach cancers as compared to breast, cervical, esophagus, and uterus is very, very low. Okay, so that disease, but still, in Singapore, if we are diagnosed at an early stage, we can still give a very good survival for our patients as compared to those who are diagnosed late. All right, I'm coming to the end. We have advances in technology. They are experimental currently, but there is advancement, and we are hoping that over time, when you put the scope, we can straight come up with a diagnosis rather than to have to wait a long term over time. All right, so we are trying to make blood tests available for the public where we can probably at least risk stratify our patients that, okay, this guy is high risk, we need to bring this patient for an earlier scope versus non-ones. Okay, so this is work in progress, and hopefully over time we will continue to share. And with that, I come to the end of my presentation.
Thank you.